Hello everyone, I hope I'm audible. Welcome to the Physics Wala MedEd YouTube channel as well as the MedEd app. I'm Dr. Patil, I'm a faculty for medicine, and in this SUSHRUTA batch class, we will be learning about the art and science of history taking. Well, medicine for many people seems a very difficult subject because they don't read it conceptually. Even those who study it well find it very difficult to apply whatever they have studied during the bedside discussions or when they have a case in front of them. The simple reason is studying theory and putting it into practice are two different ball games. They're not exactly same. Of course, you need to study theory. If mind doesn't know, the eyes cannot see is a statement that you often hear, right? So I definitely need to know something about a particular disease. Only then I will be able to diagnose. But I also need to learn to channelize my knowledge of a disease to be able to diagnose. Basically, medicine is all about diagnosis and making right choices for management. But the diagnosis is science, yet it is also art. So today we will learn how it is an art and how it is a science. Just to emphasize the importance of history in any medical case, right? Let me give you some examples. Very often I get questions from the students. Sir, if I get an ECG, what is the first thing I should see on the ECG? Now, traditionally in physiology classes and all, you have been taught that first thing you should see on the history in a ECG is that you should first see whether all the lead placement is right. After that, you should see what is the heart rate. Then you should decide what is the rhythm, whether it is sinus or not sinus. Then you should comment about the axis. There is a method, right? But as a clinician, I don't follow that method. Why? Because I never get 10 minutes time to read an ECG, right? I have a patient with chest pain in front of me who, if I take 10 minutes to analyze the ECG, will collapse and he may even, like by the time I'm ready with my ECG diagnosis, patient may not be there, right? So we need to be on the toes. Okay, so then what is the first thing that I will see on the ECG is a question. Well, as a clinician, I analyze ECG with a context. See, if someone presented to me with palpitations, so in my mind, I should already have some differential diagnosis. What is that I want to consider in this patient, right? If someone presented with palpitations, one of the differential diagnoses will be arrhythmias, right? Like for example, atrial fibrillation, PSVT, ventricular tachycardia, arrhythmias. So if I have ECG in front of me, I will see the ECGs from the perspective of arrhythmias. I will analyze it for the diagnosis of arrhythmias. Another example, if I get a patient with chest pain and I'm getting an ECG done, I already have in mind whether this patient has an ST elevation MI or no, right? That is a question in my mind. So there's a context. I will analyze the ECG with that context. So I will straight away shift my attention to the ST segments because that is my priority consideration, right? Similarly, when someone comes to us with complaints, I need to develop a context, right? What are my differential diagnoses in this case? And accordingly, I will investigate and reach the diagnosis. But if I do not have the context, then my diagnosis, like it's so hard, it's going to be so hard for me to reach the diagnosis. Just to give you an example, let us say that there is a patient who presented to me with fever. Now, when I analyze the history of the fever, like I know what is the duration, whether it is acute fever that I'm talking about, or whether it is chronic recurrent fevers, what is the fever pattern, what are the associated symptoms. When I analyze, I may be able to come out with some differential diagnosis saying that this is most likely urinary tract infection, or this is most likely upper respiratory tract infection, or this is most likely lower respiratory tract infection. So according to that, I can investigate. If I'm suspecting a lower respiratory tract infection, I would probably require a chest X-ray and a sputum analysis. Nothing more than that. If I'm suspecting urinary tract infection, I might require a urine routine and maybe urine culture. But if I'm not able to zero down the possible diagnosis, a fever case for me could be anything. So in that case, I have to do n number of investigations: CBC, RFT, LFT, urine routine, blood culture, urine culture, bone marrow studies, n number of investigations. It adds a lot of cost to the patient. At the same time, it takes away a lot of time from me. So when doctors are hard pressed for time and patients are hard pressed for money, it is wasting doctors' time as well as patients' money. Why is this happening? Because doctor is not appropriately evaluating the case, right? He is giving a blanket investigation order. So as doctors, it's our job not to do blanket investigations, but be focused and precise so that our time is saved, patient's money is saved, and also harm to patient is minimized, right? So that's why history is very, very important, because history gives us the context or possible narrowed down differential diagnosis. If you ask me, sir, tell me one important goal of history, I will say when patient comes comes to us with complaints, the main goal of history is to at least localize कि ये किस system का problem हो सकता है, from which system this problem is arising. Like if someone comes to me with cough, right, it is most likely a respiratory system problem. Sometimes it can be because of cardiovascular system problem. So I've already narrowed down where I should be looking for the diagnosis. I should be looking for in the respiratory system or the cardiac system. If someone presents to me with weakness, right, that's a complaint. I analyze, and then here I'm trying to localize. So weakness can be because of electrolyte abnormalities, or it can be because of neuromuscular diseases. So I'm zeroing down on few systems to further evaluate. But if I put little more effort and analyze history in a better way, then I might not only be localizing to a system, but also some differential diagnosis. Like, okay, someone presenting with weakness, I know it is most likely neuromuscular or electrolyte abnormalities. Now with the history, I notice that there is diurnal variation. Patient says that weakness worsens in the evening and morning he feels relatively energetic. So now from the history of further zero down, now I can think that this is most likely a neuromuscular junction disorder or myasthenia gravis. So at the end of my history, I should have as small differential diagnosis as possible. To begin with, when you're just starting your medical education, at least you should be able to localize the system affected. Better if you can come out with 2 or 3 priority differential diagnosis. So what we will do is, now first we will understand the anatomy of the case sheet or patient's record. This is how doctors communicate between different doctors. Like if I have seen a patient, I write it down everything in a format, so that any other doctor who is seeing this patient for cross referral or in my absence, or patient leaves me and goes to some other doctor, he has a clear idea what this patient is going through and what all has happened. So for that, we have this document which we call it as case sheet or patient file. So first we will understand the anatomy of this case sheet. So in this case sheet, the first and the most important thing will be the component number 1. It is patient's details, his age, gender, the residential address, occupation, and identification number. After that, we will have chief complaints, and then we will have history of the presenting illness or the present illness that is going through. Then patient's past history, that is component number 4. Then we will document family history, personal history, menstrual and obstetric history, of course only for a female patient. And then all these history parameters are summarized in a brief, succinct review or summary of whatever has happened for the patient. And then we are expected to provide a differential diagnosis. Like as a student, now what do I think? What are the possible causes why this patient could have experienced these symptoms? Like number 1, number 2, number 3. These are my differential diagnoses. When I have completed this, history is completed. Now, whatever differential diagnosis I have at the end of history, I will subject the patient for examination. During examination, what I'm supposed to do, I should be constantly searching for points which help me to either rule in or rule out my differential diagnosis. Like just to give you an example, let us say that I got a patient who presented with shortness of breath on exertion, on physical activity, is becoming short of breath and is having chest pain. So in terms of system localization, first thing that we would think of is cardiovascular problem. Second thing we could think of is respiratory system problem, right? So when I examine, I will be constantly thinking of cardio versus respiratory. So examination points that favor the cardiac disease or examination points that favor the respiratory disease. That is what I will be looking for during the examination. So on auscultation, if I get wheeze, it may be favoring towards asthma, maybe favoring towards the respiratory disease as a diagnosis. Or if patient, like on auscultation, I hear a murmur, it may be pointing towards the cardiovascular. During examination, we will further narrow down the differential diagnosis so that some of the differential diagnosis may be ruled out. And at the end of examination, I may be left with even more narrower differential diagnosis. So that now the amount of investigations I need to do to confirm the diagnosis will be minimized. If my history is not methodical, my examination is not appropriate, then I will have long differential diagnosis. Now to come out with a final diagnosis, I might need like infinite number of investigations. So the whole objective behind taking a good history and doing a good examination is to have as small a differential diagnosis as possible, and better if you have only one diagnosis left at the end of history or at the end of examination. Okay, so we'll understand how to document history today. So we'll begin with the first component. Our first component will be about patient's data or patient details. So how do I document the patient's details? So of course we will document the patient's name, age, and gender. Now from where I should document patient's age and gender is a question, because nowadays there are issues regarding that. So when we are documenting, it is the age declared by the patient. We are not supposed to do Aadhaar verification, OTP and all that. Whatever age patient declares, we will document it. If you have concern, like patient is saying, I am 20-year-old, but he's looking 50-year-old for your assessment. In such cases, maybe you can cross-question the patient for further clarification. Otherwise, document whatever is the age declared by the patient. Now, gender has become a sensitive matter today, and as a doctor, we need to be always safe. So again, document the gender declared by the patient. Document the gender declared by the patient. Patient says I'm male, document it as male. Patient says I'm female, document it as female. And patient has absolute right not to disclose the gender. So if patient says he is not willing to or she is not willing to disclose the gender, write it down. Patient has refused to disclose the gender. Okay. After that, we have to document patient's occupation. We will talk about the relevance of these points. Patient's occupation and the residential address, and equally important is patient identification number. Okay. Now, what is the relevance of documenting age and gender? Of course, as doctors, we know that certain diseases are common in certain age group, right? If a 15-year-old presents to me with weakness, I would probably not be thinking of ischemic stroke. Ischemic stroke is typically more common after 50 years of age. There are only few conditions where it can happen before that. So we call it a stroke in young. But otherwise, in a 15-year-old, stroke is less common. There are various other causes for weakness. So I will be thinking of them first, right? Similarly, there are certain diseases which are more common in females than males. Classical example is autoimmune disorders like SLE. It is more common in females. And there are a lot of diseases which are more common in males. For example, prostate cancer, of course, cannot happen in female, exclusive to males. Then stroke, ischemic heart disease or MI, peripheral vascular disease, COPD, these are all more common in males. So knowing the gender and age of the patient helps us in narrowing down our differential diagnosis. Similarly, occupation also is an important factor which you have to take history. Why? Because a lot of occupational exposures are risk factors for diseases. For example, someone working in cement industry may be exposed to asbestos, or construction industry may be exposed to asbestos. So we can develop asbestosis, a form of interstitial lung disease. Then we as doctors, paramedics, staff nurses, the healthcare workers collectively, we are at risk of certain hospital associated infections, including needle pricks, HIV, HBS, AG. So documenting occupation is important. That can also give us a sense that this patient may be prone for these diseases. Then residence is also an important. You may think, sir, what is the importance of address in patient's history? There are a lot of diseases which are endemic to a particular area, right? Those are seen only in that locality, less common in other locality. So if the patient is coming from that locality, the possibility of having that disease is more common. For example, right now, Bangalore is not reporting much cases of GB syndrome, but Pune is reporting plenty of cases of GB syndrome. So if a patient comes to me today and says that, sir, I'm having some weakness and I was in Pune for a few months and yesterday only I've come to Bangalore, it should click to my mind that, okay, he's come from a place where the increased prevalence of GB syndrome has been noted in the recent times. So then GB syndrome becomes one of the important differential diagnosis for me, right? And for that matter, we know that tuberculosis is endemic to India, enteric fever is endemic to India, malaria is endemic to India. So when Indians travel abroad, we have to declare that we are Indians so that they can think of these possible diagnoses. Otherwise, TB is quite rare in the developed world. Malaria is also quite rare in the developed world. So if you do not disclose that we are from India, they may not be able to diagnose the diseases because they are least priority diseases. Similar example, Chagas disease, which is common in the Western world, is rare in India, like not seen at all. So if some patient presents with some cardiovascular dysfunction, Chagas disease is something that I would never think of, right? So that's why documenting the patient's residence or address is important. And last but not the least, documenting the PID number. This is important not at the undergraduate medical student level, but as a doctor, it is very, very important. I'll tell you why. I'll tell you my own experience. So when I was an intern, one of my postgraduate student told me that, sir, one of my PG student told that there is a particular patient named Neelamma in this particular female ward. Go to her on a daily basis and give her a low molecular weight heparin injection on a daily basis. This is the instruction given to me. I was an intern. I was just beginning my internship. So as per his instruction, I used to go to the resident medical officer. From him, I used to collect the low molecular weight heparin, go to that patient. I searched where is the Neelamma. I found Neelamma. I gave it to her daily for 7 consistent days. 8th day during the rounds, One of the patient started complaining to our professor saying that I have not received the injection that you had told. Then PG student said like I had asked the intern to give it. Everyone started looking at me. Then I said like I'm giving it. And he's like, whom you are giving to? He told me to give to Neelama, so I'm giving it to Neelama. Unfortunately, in that ward there were 3 Neelamas, and 2 Neelamas are of similar age also. So I ended up giving the slow molecular heparin to an undeserving patient. Probably I would have caused some harm to her. And at the same time, a deserving patient did not receive the low molecular weight heparin. So that would have also caused harm to her. These kind of errors are very common in clinical practice. And one of the reasons for that is wrong patient identification. You might have heard stories of wrong leg being operated, right? Or wrong patient being operated for wrong condition. This all happens because names are so common, right? Indian names are Indian names. There are thousands of Santhoshis. There may be right now few Santhoshis in the live class who are listening to me. So then just merely knowing the name does not mean that it is the same patient that you're supposed to be dealing with, right? So that's why most of the hospitals will have a patient identification number mentioned on the file. So next time when your teachers or your PGs ask you to go and take a history, make sure that you ask them, sir, what is the patient identification number, so that you go and examine the right patient. Because see, even if you're not involved in treatment, you may lose or you may miss out on examining a very, very important, beautiful case, right? You might have a patient with RHD, with mitral stenosis, with MR and all classical findings of it. And your PG says, go and examine Neelama, she's a case of RHD, but you end up with another patient, Neelama, who is not a case of RHD, who is just presenting there with UTI. Now you spend 1 hour auscultating her, you hear nothing, right? So by the time tomorrow you realize that you examined the wrong patient and you are presenting a wrong case, the previous patient who you were supposed to examine is discharged. So you lost out, right? So always identify the right patient. And this is something that I want you to practice right from now, so that in future you don't do this mistake of giving wrong drugs to wrong patient or doing wrong surgeries on the wrong patient. Clear? So once I've documented the patient details, as we learn here, a lot of things are important: age, gender, occupation, residence. These are all important parameters. After documenting that, we will mention the chief complaints. Now, what are the chief complaints? Chief complaints are the main complaints that patient is suffering from, or the main symptoms that the patient is suffering from. Now, the question is, patient will have n number of complaints. So what will be counted as chief and what will not be counted as the main complaints? So for that, I will give you an icebreaker. What you have to do is ask the patient what brings you to the hospital or what brings you here. When you ask them what brings you here, mostly they open up the reason for them to come to hospital. That are our chief complaints. So simply ask them what brings you here. They will say, sir, because see, now, by the time you take the history during the bedside examination, the patient complaints might have changed. Like his main problem was that he was having shortness of breath. So he came to the hospital. Doctors gave him diuretics. He had pulmonary edema. It resolved, right? Now when I go to him to get the history, he's no longer having shortness of breath. So currently, his main complaint is like, I'm getting a little bit of cramps. That may be because of diuretic induced hypokalemia. So he will now say, I got cramps. So your history begins from there. Like he has cramps. Now the case is totally different, right? But your teachers wanted you to see this case from the perspective of shortness of breath, but you are now seeing it from the perspective of cramps. So the whole story changes, right? So best thing is, instead of what problems you have right now, ask them what brings you here or why you had to come to hospital. They generally open up with a detailed story, right? What all happened to them. Now they may of course have multiple complaints. So when we document their complaints, document them in the chronological order. The oldest complaint first. Like I have cough, shortness of breath, chest pain. These are my 3 complaints. You ask me what brings you here, sir. I came to hospital because I had cough, shortness of breath, and chest pain. Now I don't have any of these. Sir has told he will discharge me tomorrow, but I was going through this, so that's why I had come to hospital. Now these 3 complaints I have listed. Now you have to ask the duration of these complaints so that you can arrange them in chronological order. Cough since how many days? Chest pain since how many days? Shortness of breath since how many days? So the moment patient says, I have cough since 3 months and chest pain since 1 month and shortness of breath since 15 days, then what is the oldest complaint? Cough, right? So I will mention that cough is for 3 months. Then I have chest pain for 1 month. That is the second oldest complaint. And then I have shortness of breath since 15 days. That is the least oldest or the most latest complaint. So from the oldest to latest, we will arrange the complaints in chronological order. Now, this is not just a haphazard thought process, or this is not something that is included in case sheet to make the case sheet look beautiful. No, there's a reason why we should organize the complaints in chronological order, because every disease has a natural course of illness. To give you an example, right? Let me talk about dengue. So when dengue happens, like I got bitten by a mosquito and dengue virus has entered my body, then of course I will have that incubation period. During that time, I will not have any symptoms. And after that, the symptoms start. What are the early symptoms I will notice? I will start noticing fever, myalgia, severe joint pains, myalgia, and fever. This will run for 3 to 4 days. After 3 to 4 days, the fever may disappear, but that is a time where the platelet count starts dropping. So on day 5 or day 6, I must start noticing petechias because my platelet count is dropping. During this time itself, this is called critical phase of dengue. During this time, I can become severely dehydrated, hemoconcentration can happen, and I can go into what we call as dengue shock syndrome. That puts me at the risk of death. So now this is the natural course of the illness. So after this critical phase is over, then patient gets into a recovery phase, platelet counts improve, and the dehydration improves, and another 2 or 3 days, he will be kind of normalized. So this is the natural course of the illness. So if you tell me that first symptom that appeared was fever, and then after 4 days, petechia noticed, this aligns with the natural course of the illness of dengue. So I can start thinking about this may be a case of dengue. But if you say that petechia were the first symptoms to appear and then fever came, then it is unlikely to be dengue. I would start thinking of something else. The petechia may be because of an inherent platelet defect or drug-induced thrombocytopenia, and then fever may be because of another added infection. So the dengue becomes less likely just because the chronological order is flipped, right? So that's why whenever we document any patient's complaints, it should be documented in chronological order so that we have a clarity. And whoever is your teacher who is listening, he will get a mental idea that, okay, so looking at the progression of the symptoms, it looks like this or it looks like that. Just to give you another example, there is something called as aortic stenosis, AS, aortic stenosis. So the first symptom that we generally notice in aortic stenosis patients is angina. Few years later, they start getting episodes of syncope. Few years later, they start noticing shortness of breath or dyspnea. So if you present me a story of a patient whose complaints, like 3 years ago, he started developing chest pain on doing some physical activity, he could bear through that. And then 1 year later, he started noticing that after doing some physical activity, he started losing consciousness. And then last few months, he's having dyspnea. This is perfectly aligning with the natural course of aortic stenosis. So as a clinician, I would start suspecting that it is aortic stenosis. So that's the importance of documenting cheap complaints in the chronological order. Okay. So once I have listed all the cheap complaints in the chronological order, next component of my history is, the case sheet is going to be history of present illness or history of presenting illness. This is basically, what is history of presenting illness? It is nothing but the detailed elaboration of the cheap complaints. Like I came to you with cough, shortness of breath and chest pain. Now get more details added to my complaints. Cough, shortness of breath, chest pain. Elaborate or explain these symptoms. Okay. So when we are elaborating each cheap complaint, again, we should follow the chronological order. The first complaint that I will discuss will be the first cheap complaint. The next complaint I will be discussing is the next cheap complaint. So we will elaborate the details of each complaint in the chronological order, right? Whatever complaint I'm addressing, there are some points to cover. That includes the duration of the symptom, onset of the symptom. Onset is whether it is acute onset or sudden onset, or is it insidious in onset. See, if I say that I've got chest pain, which is there from several weeks, it's going on from several weeks, I cannot pinpoint when it started, right? So then you can say it is insidious in onset. It slowly evolved. Or if I say that I was talking to my son and then suddenly I noticed severe chest pain, I was almost feeling like collapsing and my son rushed me to the hospital. That is sudden onset. Both are not equal, right? An insidious onset chest pain can be because of various causes. It can be because of, let us say, like it can be because of various causes. Just to give you an example, it could be because of the musculoskeletal problems of the chest, right? It could be because of the costochondritis. But if it is sudden in onset, like within seconds to minutes it evolved, it could be because of MI, right? It could be because of spontaneous pneumothorax. It could be because of the dissection of aorta. So the possible causes change depending on the onset. So you have to document onset. Of course, duration, whether it is 2 months, 1 month, or 15 days. Duration after that onset, whether it was sudden onset, acute onset, or insidious onset. After that, we have to document the aggravating and relieving factors. If I say I got chest pain, which gets aggravated when I take deep breath, right? Just to give you an example, let us take the example of chest pain as a complaint. Okay, so now I have chest pain, which is acute in onset, started just few hours back. Okay, now it is increased on inspiration, and I say that it gets decreased when I'm exhaling out. On expiration, it is decreasing. Can this be a case of myocardial infarction? Can this be a case of myocardial infarction? Quite unlikely. A pain of myocardial ischemia, right, that is angina, will not have any relationship with the respiration. Whether I am taking an inspiration or whether I am doing expiration, the pain will persist. But the pain because of pericarditis or pleuritis, that will worsen on inspiration and decrease on expiration, right? But instead, I say I got chest pain, which gets worse on exertion. I walk or I do some physical activity, it worsens and it gets decreased or it disappears on rest. This is more suggestive of angina, right? So angina has its own aggravating and relieving factors. Angina gets aggravated by physical activity or exertion. Angina gets relieved by rest or nitrates. If I take a sublingual nitrate, coronary vessels dilate, more blood goes to the heart, and my chest pain may disappear. But if I say my chest pain gets worsen on inspiration and decrease on expiration, it is pointing towards pericarditis or pleuritis. If my chest pain has some positional relationship, like the chest pain worsens when I lie down, but when I sit and lean forward, it is better, again, it is pointing towards pericarditis or pleuritis. So that's why whenever we document a complaint, we should document about the aggravating and relieving factors. Okay. Along with that, sometimes there may be associated symptoms which we will try to include. Soumyadeep Sarkar, absolutely right. Shivam Gaur, thankfully I am safe. Patient was also safe, but I'm just highlighting. So every medical establishment every year reports quite a good number of such medical errors. So at the end of the day, we are all human beings and we are prone to do errors. And these errors are minimizable or reasonably preventable provided everyone follows the methods. But unfortunately, what happens is everyone learns the lessons after burning their fingers. So that was the tipping point for me. I realized that I have to address patients by looking at the patient identification number and not by just name. So since then, I have not mismanaged any case just because I identified the patient wrong. So whatever I have learned, I'm just putting it across to you so that you don't do the same mistakes, right? Okay. Okay. So in terms of patients, okay, see, when something is very slowly evolving, right? Patient says that he cannot pinpoint when exactly it started. It started a couple of days back or a few weeks back. I cannot say at what exact time it started, but it started and then it has slowly progressed, right? Then you can say that it is kind of insidious in onset. But when patient can pinpoint and say that it started at this particular time or this particular part of the day, we will either call it as acute or sudden. Now the difference between acute and sudden is where patient clearly says that he was absolutely fine and then out of nowhere the symptoms started. Like I'm talking to you, now I experience suddenly chest pain, I will call it as sudden. But I'm talking to you, I have some discomfort, I may have a feeling that there is some chest pain going on. It evolves over next half an hour, 1 hour, 2 hours, then I will report it as acute onset. But if it is spot on beginning and the moment it starts, it start disturbing me and I have to present to you, then I will call it as sudden onset. So the sudden onset is word which is kind of restricted to, because if the onset of a symptom is sudden, mostly patient land up in emergency room. Like sudden onset chest pain, right? Or sudden onset pain anywhere, patient mostly land up in emergency room. Most patients who walk into our OPD, they have either the acute onset symptoms or insidious onset symptoms. Okay. Now I was talking about so-called associated symptoms. What are these? To give you an example, let us say we are talking about a patient with shortness of breath. Shortness of breath. Now, shortness of breath, can you list some causes? It can happen because of COPD, right? I can have shortness of breath when I'm going through an asthma attack. I can have shortness of breath when I have left heart failure, right? Heart failure in simple words. I can have shortness of breath in aortic stenosis. I can have it in mitral regurgitation, mitral stenosis, or in simple words, any of the left-sided valvular heart diseases, right? Aortic regurgitation, in all these conditions. These are all my possible causes for shortness of breath. There are again a long list of causes for shortness of breath. I'm just summarizing few. Now, along with this shortness of breath, if I tell you that my shortness of breath becomes worse when I lie down, but it becomes little better when I am upright, what do we call this symptom as? I have shortness of breath, but it is worse when I lie down, and it is much better when I am upright. We will call this condition as orthopnea. Orthopnea. Orthopnea is a subtype of dyspnea or shortness of breath. So I should document it because orthopnea points towards most likely a cardiovascular cause. There are other causes, but most likely a cardiovascular cause. Now, if I also say that my shortness of breath becomes worse in the night, which makes me wake up from my bed, go to the window, seek air, I feel little relieved, I go to sleep, then again the cycle repeats. Then we call it as paroxysmal nocturnal dyspnea, which is the most specific symptom of left heart disease. So it points towards these possibilities or left heart failure. That is one of the associated symptoms, right? Or if my shortness of breath is also associated with, let us say, cough, it points towards COPD. So whatever associated symptoms are there, which can help you to zero down your differential diagnosis, we will mention along with the elaboration of that particular complaint. Okay. Then this is where most of the students get confused. We should document relevant positive and negative history. What is this? And I know this is where most of your professors hold you to your collar and then start insulting you or questioning you more, right? And this is where most of the case discussions get stuck during bedside discussion. You say something, then they will ask you, why did you ask that? And then you're like, you will start giving some logical reasoning for that. Sir, I asked this because I was thinking of tuberculosis. Then your examiner says, oh, in this case, you're thinking of tuberculosis. In this case, common scenario, right? I think most of you can relate to it. Okay, so today we will try to make it easier. Sutapa Samanta, syncope refers to transient loss of brain's function leading to maybe loss of consciousness because of reduced blood flow to the brain, which is transient reversible. If it is permanent, of course, it will result in stroke, which is transient. Then we call it as syncope. Classical example in aortic stenosis, aortic valve opening is very narrow, right? So the amount of blood that ventricle can pump to the aorta is reduced because of the narrow opening. So less blood goes to the brain. So sometimes we can feel dizzy, faint, or fall. That is our syncope. Okay. So then comes the question. If I do not want to get caught by my teachers, what should I cover in the positive and negative relevant history? So every complaint, whenever I read every complaint, in my mind, I should make a list of possible differential diagnosis. And I should ask only those points which I know can help me to rule in or rule out my possible differential diagnosis. Right? If I say that there is a patient who presented with shortness of breath, I'm thinking of respiratory disorders and cardiac disorders. So now I should ask questions to patient. For relevant history, positive or negative history, we can always ask leading questions. I should ask the patient, did you have worsening of shortness of breath when you lie down, and do you feel it goes away or it gets better when you get upright? I'm trying to extract the history of orthopnea. If patient says yes, I will mention, so there is history suggestive of orthopnea, or I can even directly mention in patient's words saying that the patient feels his shortness of breath gets worse on lying down and it gets better on taking an upright posture. This is where examiners will ask, why did you ask that? Sir, I wanted to know whether patient has got orthopnea. How is it relevant to this case? Sir, because this patient presented to me with shortness of breath, I want to think whether it is a cardiovascular case, and presence or absence of orthopnea can help me to differentiate whether it is a cardiovascular case or not. If orthopnea is present, it is pointing towards cardiovascular case. So if it is present, you will mention it, so then it becomes a relevant positive history. If it is absent, you will mention that, then it becomes a relevant negative history, right? Similarly, like we are talking about shortness of breath. Patient chief complaint have not listed anything about wheeze, but I will still ask because asthma is a possibility, right? So I will ask, do you get episodes of wheezing? If the patient says, yes, I get episode of wheezing, I will document it that this patient's shortness of breath are accompanied by episodes of wheezing. So now asthma becomes a possible differential diagnosis. If it is absent, I will mention the patient experiences shortness of breath, but it is not associated with wheeze. So that kind of helps me to move away from the diagnosis of asthma. So then it becomes a relevant negative history. But just because you need to ask something or add something, don't go on asking random questions and mentioning their answers in the history. Don't make a history sheet big documentary. Only ask those questions which will help you to rule in or rule out differential diagnosis. And again, restrict to what you know. Then how will I get my better vocabulary so that I can ask more relevant questions related to positive or negative history? That you will learn as time progresses, right? As you start seeing more and more cases, the complaints, symptoms start becoming more evident. Or for example, like we have done this Harrison series in which I have discussed how do we approach cough, how do we approach jaundice, how do we approach fever. So during those approaches, you learn like, okay, if someone presents with jaundice to me, I have two differentials, whether it is obstructive jaundice or hepatocellular jaundice or non-obstructive jaundice. So what points I need to ask in the history to know whether it is obstructive or non-obstructive? Those are the questions I will ask so that now I know whether it is obstructive or non-obstructive. Good for me, good for the patient, good for the examiner. If I am dealing with a, let us say, patient with chest pain, right? I have my differential diagnosis made up in my mind. Chest pain can be because of pleuritis, pericarditis, angina, right? It can be because of pneumonia. It can be because of pleural effusion. All these are possible causes. So now I will ask questions which will help me to zero down. So I will ask whether the chest pain is worse on physical activity and it gets relieved on rest or nitrates. If patient says yes, it is most likely angina. So I will mention it that this patient chest pain is worse on physical activity and it is relieved on rest. Examiner will be happy because he knows that you know the approach. And if it is not there, I will still mention it because it is a relevant negative history, because that tells the examiner me that this patient is not mostly because of angina. His chest pain is because of something else, because it has no relationship with physical activity and rest or nitrates. So those points we will mention in the relevant negative or positive history, right? Okay. Now the same template will be followed for all the chief complaints. So history of presenting illness should look like this patients are presented with cough since 3 months. The onset was acute or insidious, whatever it was, and it gets aggravated on exposure to dust. It gets relieved on rest or medications. It is associated with sputum. Now, if I'm talking about an associated symptom, if it calls for more detailed elaboration, I should elaborate. It is associated with sputum. Now, I will also describe the sputum. The sputum is rusty colored or yellow colored, greenish colored, or is it putrid or looks like normal colored? Right? What is the quantity of sputum, whether I can call it as copious or scanty, whether this sputum production is continuous or intermittent, it comes in for a few days and then it goes away. So I will elaborate again associated symptoms also with a very similar template. And after that, I will add the relevant positive or negative history. Now that I told you that this patient is coughing from 3 months, the possible differential diagnosis for me are the chronic bronchitis of COPD. Right, in India, tuberculosis is always a differential diagnosis for anyone who is coughing for 2 months or more. Then asthma is also a possibility. And then interstitial lung diseases are the possibility. So now I will ask, right, among interstitial lung diseases, occupational disorders are also possibility. So now I will ask questions relevant to zero down the differential diagnosis. Okay. So what relevant questions I will ask? I will ask exposure to TB, right? Whether patient has come in contact with any case of TB. If yes, I will mention it. That becomes a positive relevant history. If no, I will mention it. Then it becomes a relevant negative history. That patient has no exposure to tuberculosis or no contact history with tuberculosis, right? So if patient is working in a construction industry or sandblasting industry, he may be prone for asbestosis or silicosis. So I will ask questions related to his occupation and I will document that there is no history of occupational exposure to silica or asbestos. That kind of takes me away from the asbestosis or silicosis as possible cause for this patient 3 months cough. And if it is there, I will document it because that makes it closer to that diagnosis, right? So that is how we will document our history of present illness. Every complaint, give the details in the template I have given you, and at the end of it, ask the questions for ruling in or ruling out the differential diagnosis. The next complaint that we have listed in the chief complaints, whatever is the second complaint that we have listed in the chief complaint, will be elaborated in the same manner. The next complaint in the same manner. So at the end of it, when all the complaints are described, history of presenting illness ends. So after history of presenting illness, the next component of our case sheet is past history. Now again, here a lot of students get confused. What is past history? What is past history? Like, I came to you with fever and burning micturition from 3 days, and I've been diagnosed with diabetes 1 year back. So diabetes should be my presenting complaint, or should it be put in past history? What should be the presenting complaint here? Fever and dysuria from 3 months should be presenting complaint, and diabetes should be put in past history. Or my main complaint is diabetes since 1 year, fever since 3 days, and burning micturition since 3 days. Right. So remember, that's why I told you the best way to extract the chief complaint is asking them what brings you here. So they will tell you for what reason they are here. Anything that predates their current reason for coming to hospital is going to be past history. So if you ask me, sir, what brings you here? I'm coming to you because I'm having fever from last 3 days and burning micturition. So that becomes my chief complaints. And anything before that is past history, right? So in the past history, we should document all the relevant medical history, including the comorbidities, which includes like diabetes, hypertension, COPD, whatever patient is having, right? Other medical illnesses, COPD, hypertension, ischemic heart disease, whatever comorbidities he has. We should also mention the duration. If you say that, okay, he's diabetic, for how long he is diabetic. If it is COPD, for how long he is COPD. And then all the previous hospitalizations should be documented in the past history. And then any procedures or surgeries patient has undergone should be documented in the past history. At the level of past history, don't think whether it is relevant or not, because it may be or it may not be relevant to the current complaints, but we should still document it. It's like patient has undergone gallbladder surgery. Now he has come with, let us say, like he has undergone gallbladder surgery 20 years back, and now she has come with chest pain. Probably not related, but still we have to document it in the past history. So I have a question here. If a patient was hospitalized, underwent a procedure or surgery for a present illness, should it be included in the past history? Like, okay, I came to the hospital with a right upper quadrant abdominal pain. Doctors diagnosed that I have gallbladder stones, and it was also causing CBD obstruction, and they eventually operated me. I have undergone cholecystectomy. Okay. Now you are seeing me on post-operative day 3 or day 4. Now, should this surgery be part of the past history or the present illness? So remember that, again, I'm emphasizing, past history refers to relevant medical history prior to the onset of the oldest chief complaint. And the best way to extract chief complaint is asking them what brings you here. So whatever brought them to the hospital, anything before that, anything that predates is going to be past history. But here the patient came to us with the abdominal pain. Later on, we found out a cause and operated. So the surgery is part of the present illness. It is part of the story. So you will elaborate on this surgery in the history of present illness, saying that the patient presented to the hospital with 4 days of severe abdominal pain, and on evaluation, this was diagnosed, for which patient has undergone this particular procedure. It becomes part of the present history, right? It is part of the present history. Only symptoms that predate the oldest chief complaint will be included in the, should be considered as part of present illness. Okay, so I hope now you have the clarity of what goes in chief complaints and what goes in the past history. Okay, so after documenting all the relevant past history, the next component of our history is going to be family history. So in the family history, of course, we will document if there is any family history of similar illness. It need not always be about genetics. It's also about lifestyle. A lot of diseases are common in families where genetics may not be playing very important role, but still they are living in the same environment. they are probably part of the same cultural practices. They're probably part of, I mean, they're probably having the similar diet, similar lifestyle. So a lot of diseases can manifest even when genetics is not responsible. Just to give you an example, there are a lot of religious practices in the country where, like, the consumption of meat is not acceptable to many families. Of course, it is a personal choice. It's not. I mean, I'm not saying that it is a wrong practice or something. It's a personal choice, but that pure vegetarian diet puts them at risk of B12 deficiency. I myself a vegetarian, and I'm often my B12 levels go down because that's how it is. There's no good source of B12 in the vegetarian diet. Now here, genetics doesn't matter, right? If I'm becoming B12 deficient, my whole family is vegetarian, so they are also probably going to become B12 deficient, right? So you should always ask, even if you're not thinking that this patient's particular present illness might have a genetic basis, you should always ask whether there is family history of similar illness. For two reasons: because they're part of same cultural practices and they're living, eating, and breathing the same space. In the same space, they are prone for similar illnesses. Second, infectious diseases spread first mostly within the family and then outside. So that's why you should always ask history of similar illnesses in the family. And then you should always ask relevant medical illnesses in the family. Now, what is this? Similar illness, I understood. Okay, this patient is presented with cough, chest pain, and shortness of breath. I will ask, does anybody in your family has the same problem? Patient will say either he has or he doesn't have. Okay. Then there may be a lot of other things going on in the patient's family, which you may not be able to directly extract until and unless we ask a leading question. Patient may not answer, but still it may be relevant to us. And better would be that ask them a straight question. Is there anything important, or is there any history of medical problems in the family that you expect me to know? Patients generally open up and say. I'll give you an example. So I had a young male, I think 26 or 27, and he had come to me with profound weight loss. He had lost more than 15 kgs in a span of 3 months. I had first seen this patient's wife for fever, and second time when he came, I could not recognize him because he had lost 15 kgs of weight, unintentional. And when we were planning to evaluate in detail, I just asked him a question like, is there any medical problem in your family that you want me to be aware of? And then patient made a list of family members who have died with cancers at young age. He said, like, my cousin died at 35 with cancer. She died at 28 with cancer. So that alerted me to think of some inherited cancer prone syndromes. And when we evaluated, it turned out to be that he had a case of CA colon, right? So I could extract that only by, otherwise I should have asked him, like, has anybody else lost weight in the family? And it's quite difficult to reach to the point, right? But what I did, I just asked him, is there any major medical problems is going on in your family that you want me to know? And he opened up and gave me the story, right? Then last thing that I would document in the family history, if I consider that there is a significant family history and it is most likely following a Mendelian inheritance pattern, then I should put a pedigree chart. In medical cases, pedigree chart is not always required because in adults, most of the diseases that we are diagnosing may not be following a Mendelian inheritance pattern. But if you feel it is following, for example, if you're dealing with a case of maturity onset diabetes in young, which follows autosomal dominant pattern, we can clearly document that 3 generations had the diabetes. So if you're suspecting, put a pedigree chart. If you feel like there's unlikely to be a Mendelian inheritance pattern being followed and it is a multifactorial disease or polygenic inheritance, then at least mention whether similar illnesses were there in the family or not. Okay. So after that, we go to the next component, which is personal history. Personal history. So in the personal history, we will document his bowel and bladder habits. Seemingly insignificant factor, but it does play an important role in diagnosing various disorders. We should document whether their bowel movements and bladder movements are regular or irregular. If they have noticed any particular abnormal patterns, ask the patient and document it. Why is it important? There are a lot of diseases where bowel and bladder patterns get altered. For example, right? For example, in patients with let us say hypothyroidism increases the risk of constipation. A patient is hyperthyroid, they can have diarrhea or increased bowel movements. In case of hypothyroidism, decreased bowel movements or constipation, right? Similarly, in patients with Parkinson's disease, there is decreased bowel movements. So similar to hypothyroidism, they can also become prone for constipation. In fact, even before the onset of tremors, rigidity, and bradykinesia that we classically describe in Parkinson's disease, many patients would have developed two symptoms early. One of them is anosmia, and the second one is constipation. This history may be evident when we ask them retrospectively. Most of the Parkinson's patients say that tremor started 2 years back, but loss of smell was there for 10 years. Constipation was there for 7, 8 years. Those are early symptoms, right? Then we can also have bowel and bladder incontinence in various neurological disorders, spinal cord injuries. So we should ask this history. Okay. Then we should ask about the appetite. Appetite may not directly help you to diagnose or refute a diagnosis, but it gives you an idea, because a patient, especially those who are having chronic illnesses, they might be having weight loss, and this appetite gives me an idea whether the weight loss is because of reduced intake or it is because of having normal intake but extra burn. For example, if I have a patient with hyperthyroidism, patients with hyperthyroidism will have increase in the appetite, but still they are losing weight because their metabolic rate is very high. They are burning calories like anything, so they will be losing weight. So this patient has weight loss as a complaint, but his appetite will be increased. On the other hand, I have a patient with hypothyroidism. These patients' appetite may be decreased, but still they are gaining weight because of the decrease in the metabolic rate. So by understanding their relationship with appetite and weight loss, we may be able to get a rough idea whether this patient's weight gain or weight loss is related to increase or decrease intake or not, whether it is related to an illness or decrease or increase intake. Okay. Then we have to document about the patient's diet. When we document the diet, we have to document whether he is a vegetarian or he is a non-vegetarian. And of course, in India, there are a lot of vegetarians who consume egg. That also we should be documenting. Now, what is the relevance of diet? Well, the vegetarians are prone for certain diseases. For example, B12 deficiency, right? Then non-vegetarians are also prone for certain diseases. For example, neurocysticercosis. Neurocysticercosis is typically more common in non-vegetarians than vegetarians. And then patients consuming egg, if someone who is very gym enthusiast, bodybuilder, and he's taking 20, 30 eggs a day, right? Iodine in the egg may be increasing their biotin deficiency. So there is no perfect diet as such. So each dietary practice has certain pros and cons. So it is better that we document so that later when we analyze possible differential diagnosis, this helps us. For example, like I had a patient a couple of weeks back who presented with tingling sensations in his feet. He is not a diabetic, but he had told me that he is vegetarian and he has turned vegan. Okay, you should that also, if a patient is vegan, document that also. He has turned vegan for last 2 years. What is vegan? Someone who does not consume even dairy, no animal product on their plate. So for me, from the history, it is clear that it is most likely B12 deficiency causing peripheral neuropathy, right? So I got the B12 levels checked, turned out to be critically low. So we started him on the replacement, and hopefully in a couple of weeks to months, his B12 levels will get normalized and he should start doing relatively better, right? Then we should document about sleep, right? So we should document about the sleep duration, whether patient has any insomnia or hypersomnolence, increased sleepiness. And if relevant, right? If relevant, when we document about sleep, we should also talk about the daytime alertness. Now, why is that important? Let us say that a patient says he's sleeping 6 hours. Okay. And he feels that he is fully alert during the day and he doesn't feel like there is a urge to nap or he's not falling asleep unnecessarily. That means good for him. Sleep is adequate for him. Ideally 7 to 8 hours, but with 6 hours he's doing fine. On the other hand, I get another patient who says he sleeps 8 hours, but then he feels sleepy during daytime, right? He dozes off without any warning during daytime. What does that indicate to me? The quality of sleep, even if it is he's having 8 hours, is not good. That's why he's sleeping or he's dozing off during day. So that points towards the possibility of obstructive sleep apnea. That's why his quality of sleep is gone down, right? So when we document about sleep duration, whether he has got any insomnia or hypersomnolence, and whether there is any decrease in daytime alertness. daytime alertness. These should be documented. Okay. After that comes the addiction or habits. So in the addictions or habits, we will document about alcohol, right? Smoking and other banned substances. Other banned substances. So when we are expressing alcohol, we should express the grams of alcohol taken per day, grams of alcohol per day. And if you're expressing smoking, right, smoking should be expressed in pack years. Pack years. Why the quantification and the duration of habit is important, right? We should mention the quantification and the duration, from how long patient has been drinking and from how long the particular patient has been smoking. Okay, why quantification is important? Because certain diseases become evident after a particular duration and quantity of exposure. Just to give you an example, COPD, right? COPD becomes more common after 15 pack years of smoking. 15 to 20 pack years of smoking. If someone is smoking for 6 months, he is unlikely to develop COPD. So if I get a patient who has been smoking for only six months, now he is coming with cough, expectoration and shortness of breath. He can be having any other condition but unlikely to be COPD. 6 months of smoking is unlikely to cause COPD. It needs 15 pack years. Now what is this pack year, or how do we calculate it? Pack years is defined as number of packs of cigarettes smoked per day, number of packs of cigarettes smoked per day into number of years smoked, number of years smoked. See, it's such an intriguing parameter. Pack years is equal to number of packs of cigarettes smoked per day into number of years smoked. Just to give you an example, right? Let us say there are two people, patient A and patient B. You should tell me in whom I should suspect the high likelihood of COPD. I got the smoking history of both of them. Patient A smokes 1 cigarette per day and he has been smoking for 15 years. And patient B smokes 1 pack of cigarette per day and he has been smoking for 3 years. 3 years. Okay. Who has higher risk of developing COPD? Or like who is closer to becoming diagnosed with COPD? Right. So what is the pack years for patient B? Anand Krishnan, Jojo, very good. What is the pack years for patient B? 1 into 3, that is 3 pack years. What is the pack year for patient A? 1 cigarette per day, right? Remember, when I say pack, 1 pack refers to the international packs. There are 2 packs, an Indian pack and an international pack. Of course, the pack years has to be standardized globally, so it's an international pack. International pack contains 1 pack is equal to 20 cigarettes. 20 cigarettes. Okay, so here how many packs per day he is smoking? He is smoking 1 by 20 into 15. So that is 15 divided by 20, that becomes 0.75, right? 0.75. So patient A has 0.75 pack years. Patient B has 3 pack years. So who is more closer to COPD? Of course, he still has a long journey to reach before he develops COPD, but he is much more closer to developing COPD than patient A. He has been smoking for 15 years. This person had been smoking for just 3 years. So this is how we can match the quantity and duration to assess the relative risk of someone developing a particular disease, that is COPD in case of smoking. So whenever we talk about smoking, document it in terms of pack years. Okay. Apart from that, if patient is addicted to any of the banned substances, nowadays it is very common in medical hospitals to get weed or MDMA. So if it is so common in medical colleges itself, then of course it will be very common in the society. And every day when I open the newspaper, I get this news that the police confiscated some banned substance in some corner of Bangalore. It's so common. So make it a point that you ask. Many times patients don't open up. If they open up, it adds to the ease of diagnosis. Many times the substances themselves may be the reason for the patient's complaints. Like again, I can tell you an example that when I was a PG student, we had a case who presented with repeated attacks of chest pain. The story of chest pain is very similar to angina. It's like it comes, but after some time it goes away. It is associated with little bit of sweating, very similar to angina. But when angiogram was done, it turned out to be negative. So initially, the cardiologist thought this is Prinzmetal's angina or vasospastic angina. But repeated approaches to history, finally we realized that patient was abusing cocaine, and cocaine itself was causing the coronary artery spasm and giving the classical picture of angina, right? Any other forms of tobacco exposure, unfortunately, we do not have a standardized formula, but if patient is having other forms of tobacco exposure, document it under the banned substances, saying that patient consumes tobacco in this particular. So after we have documented the personal history, we will move to the component 7, which is menstrual history. Of course, relevant only for a female patient. Don't document it for a male patient. This often happens in medical colleges, that you are presenting a male case, and because you're just writing it down, you're filling the blanks in a pro forma which is printed and available to you. You utter, sir, coming to menstrual history, and then your examiners tear you down. Right? So make sure the moment you mention that the patient gender is male in your initial case, be sure that you should not be talking about menstrual history. Now, what will I document in menstrual history? I will document the age of menarche. If patient has already undergone menopause, the age of menopause. And then if it is female and she is past menarche and she is of the legal age to have a family, then GPLA, that is gravida, para, living and abortions. And then flow, right? Whether there is oligomenorrhea, menorrhagia or amenorrhea, document that. Now you may be thinking, what is its relevance in medicine case, sir? Why should I talk about menstrual history for a medical patient? If it is obstetrics, of course it is relevant. No, in medicine also it is relevant. For example, if someone presents with menorrhagia, hypothyroidism is a possibility, right? Then there are a lot of endocrine abnormalities where the early menarche or delay in menarche can happen, right? A lot of endocrine disorders can disrupt the menstrual history. So that's why documenting menstrual history is relevant even in medicine cases. Okay. So after the menstrual history, the next component is to summarize the story. Now, as a teacher or as your examiner, what do I expect in the summary? The summary should be like a storyteller, right? You should be telling the story of the patient. It should not be haphazardly, randomly quoting some complaints and some symptoms, and then at the end of it say that this is the diagnosis. The listener, whether it is an examiner or a co-PG or a colleague or another doctor, he should get an idea that what all has happened to the patient in a very cinematic way, saying that, sir, this patient was apparently well 3 months back when he started noticing cough. The cough was insidious in onset and it was slowly progressing. It was associated with scanty sputum. The sputum was non-putrid, or it was not greenish in color, or it was not putrid. And then along with that, whatever only relevant point I will mention here, right? I might have asked some 4 or 5 relevant questions for negative or positive history, but the one that is relevant here, extremely relevant. This cough is not associated with hemoptysis or weight loss. This is a relevant point because in tuberculosis, we can have hemoptysis. In tuberculosis, we can have weight loss. So you're mentioning that relevant point. And then this patient also has chest pain from last these many days. Then again, relevant points. This patient also has shortness of breath or dyspnea from these many days. Again, relevant points. Right? He has history suggestive of orthopnea, or he has history suggestive of PND, or he does not have history suggestive of PND. Relevant, right? A very concise description in a same chronological order so that the listener can picturize what all patient has gone through in a sequential manner. So it is basically only talking about important points from HOPI, personal history, family history, and menstrual history. Now we have documented everything in detail, but here you don't have to mention everything in detail, only the relevant points. Like in the family history, if I notice that there was similar illness in the family, then only I will talk about it in the summary. If there's nothing significant, I won't talk anything about it. In the personal history, okay, he is a smoker and he has, let us say, 10 packets of smoking, then only I will mention about it. Otherwise, I will not mention about it. It's not relevant. Then I will not mention about it. So summary, keep only things which are relevant. Like when you see a movie, It's a 3-hour movie, but if you ask someone to tell me the gist of it, he can tell you the story in 4 or 5 minutes, right? By keeping only relevant points. A lot of things happen in the movie. There are a lot of jokes, comedy scenes, all are filtered out, and he gives the essence to you. Same way, give the essence to your examiner in the summary. Once the summary is completed, the last component of our history is going to be differential diagnosis. This is where again you can get into trouble in the early stages, but I will try to make it simpler as we go through this series, where we will discuss about approach to individual complaints, so that when you learn the approach to complaints, you will be able to document your differential diagnosis easily, right? Just to give you a small work now, that here I had listed some complaints, right? This patient presented with cough, chest pain, and shortness of breath. At least at this level, we have not done any history taking or anything. We have only documented complaints. Tell me what are the differential diagnoses you can think of. Someone with cough, chest pain, and shortness of breath with the duration that is mentioned here. Can it be because of pneumonia? Can it be because of pneumonia? Pneumonia is unlikely. Why it is unlikely? Because by 3rd or 4th week of onset of symptoms, right, either you worsen, you deteriorate critically, and you land up on ventilator, you're in a hospital, or you might not even make it, or you start recovering. You will not have symptoms of pneumonia persist for 3 months. Unlikely. Yeah, tuberculosis is a possible differential diagnosis. I agreed. That's a good point. Okay. What else it can be? Can it be a lung cancer? Carcinoma of the lung? Right, bronchogenic carcinoma? Possible. That can persist for 3 months or more. That can cause chest pain. Right? When it invades and takes up space inside the thorax, it can cause shortness of breath. It can trigger cough. So that is a possibility, right? Lung cancer is a possibility. Yes, interstitial lung disease is a possibility. It's a bit difficult to explain the chest pain from the interstitial lung disease directly, but yeah, a good student can defend saying that interstitial lung disease can lead to pulmonary hypertension. Pulmonary hypertension can lead to right ventricular hypertrophy. Right ventricular hypertrophy can lead to right ventricular ischemia. That can trigger chest pain. Okay, so possible differential diagnosis, I accept. Okay, what other differential diagnosis we can think of? Yeah, so therefore we're not talking about history. We're only talking about differential diagnosis at the level of complaints. TB, lung cancer, interstitial lung disease. Okay. Can I have cough in cardiac problems? Like if I have mitral stenosis, can I have cough? If I have mitral regurgitation, can I have cough? Yes. Why? Because whenever we have left-sided lung problems, left-sided heart problems, right? Like let us say this is my left atrium, this is left ventricle, this is aorta. We know that blood comes to left atrium from the lungs through what we call as pulmonary arteries. So if there is pressure building up inside the left side of the heart, eventually it will reflect to the pulmonary capillaries in the lungs. So we can have pulmonary congestion. So that need not only cause shortness of breath, but that can also cause cough. Possible, right? So chronic heart failure, mitral stenosis, all of those. I will just put it simply as left heart disease. Whether it is left heart failure, mitral stenosis, or any of the valvular diseases, right? All of them can also present with these complaints. So these are my differential diagnoses at the end of cheap complaints. Now, when I take the history, I will try to find out points favoring or refuting these, right? I will ask whether there is weight loss, evening rise of temperature, night sweats related to TB, right? I will definitely emphasize on the smoking history related to lung cancer. I will also ask about hemoptysis, which are common in both of these conditions, right? When it comes to ILD, I will look at patient's age. Most of the ILDs are common. The IPF is more common in elderly. Then occupational exposure, asbestosis, silicosis, they are all ILDs. So that I will focus on. Then with respect to left heart disease, there are a lot of things that I can ask. For example, mitral stenosis is usually because of rheumatic heart disease. So I will ask history of rheumatic fever in the past, or episodes of sore throat triggering the systemic manifestations in the past. So when I take all that history, I may be able to zero down on few differential diagnoses. Like let us say by looking at the history, I have ruled out left heart disease. There is no orthopnea, there is no PND, right? There are no other pointers towards left heart disease. Or maybe I have also ruled out the interstitial lung disease, looking at the history pointers. And if I'm only left with now TB and lung carcinoma, then at the end of history, my differential diagnosis further narrow, right? So now I will mention those two differential diagnoses in the history. So when I'm documenting those possible differential diagnoses, again, I have to document it on the priority basis. What is the most likely and what is the least likely? So again, for that priority, history may be giving me clues, right? Like if I say that there's a patient who presented with cough, shortness of breath, and chest pain from 3 months. This cough is associated with sputum, and there is history of tuberculosis exposure. The patient's cousin was diagnosed tuberculosis 3 months back, and they live in the same house. That makes TB more likely than lung cancer, right? Or on the other hand, it's a known case of COPD, and he has lost 15 kg of weight in last 6 months. Significant weight loss there. So then lung cancer becomes equally important differential diagnosis, right? So whichever appears to be the most important will be documented first, and whichever appears to be the least likely in this scenario becomes the last differential diagnosis, right? So at the end of your history, you should have smallest possible list of differential diagnoses. That is our goal. So the more better we become at taking history, our differential diagnosis becomes narrower and narrower. Now, once this is done, our case sheet history taking is complete. After that, we start the examination. Now, what is the goal of examination? Again, the goal of examination is trying to figure out among the possible differential diagnosis, what should be my provisional diagnosis. Like I have list now, like list of suspect criminals. Now, when I subject them to interrogation, I should be able to figure out who exactly has done the crime, right? So that is the goal of physical examination, which we will discuss in the next class. So in the next class, we'll talk about the physical examination, where again we will understand what is covered in general physical examination and what is supposed to be covered in systemic examination. So this will be our basic. Like we have understood how we should prepare for the bedside clinics in the previous class. Today we have understood how my case sheet should look like, what goes where, and what points I should ask or consider in the case sheet. And in tomorrow's class, in the next class, we will discuss about the examination, which is going to be little basic general physical examination and basic approach to systemic examination. And after that, we will start with individual system. When we go to individual systems, we will take up individual complaints. For example, we will start with the respiratory system. If we are starting with respiratory system, we'll understand how to analyze cough as a symptom, how to analyze shortness of breath as a symptom, right? How to analyze wheeze as a symptom. So after analyzing the symptoms, we will discuss about the examination of respiratory system. So we'll follow the same template till all our systems are completed. And hopefully at the end of SUSHRUTA batch, you should be able to confidently present cases so that when you enter your final year, the case presentation or bedside clinic is no more a burden, which is already done and dusted. And you can start concentrating more on learning the theory and MCQs for your prof as well as the NEET PG exam. Okay. If a patient has completed TT of RF in the past, so later on, can he present with RHD or other complaints? Okay, see, remember, I will tell you something very important, conceptual. What is this rheumatic fever and what is rheumatic heart disease? So basically, rheumatic fever is an autoimmune disorder, right? It is an autoimmune disorder. Many times students think it is an infectious disease. No, it is not an infectious disease, it's an autoimmune disorder, which is triggered by infection. Which infection? Group A, beta hemolytic streptococcal infection, right? Gas infection. Gas infection triggers our immune system to produce the antibodies, and those antibodies start causing the damage to multiple organs. So it's a multi-organ autoimmune disorder. It is not just a cardiac problem, right? That's why you get this erythema marginatum, which is basically involvement of skin, right? You get migratory polyarthritis, which is basically involvement of musculoskeletal system. You can get Sydenham's chorea, which is basically involvement of the nervous system. So it's a multi-system or multi-organ autoimmune disorder. One of the organ affected, right, among those is going to be your heart. And in heart, what it causes? In heart, it causes pancarditis. What does that mean? It affects all the structures of our heart. All the structures of our heart. In the sense, pericardium, endocardium, myocardium, and valves. So one of the structure affected is valves. So what happens to valves? It causes valvulitis. Valves get inflamed. And once the valves are inflamed, They may not be able to close properly because they are inflamed or swollen. So it can lead to regurgitant lesions. The most commonly affected valve is mitral valve. So it can cause mitral regurgitation. So when I have rheumatic fever, I may end up developing mitral regurgitation. Now from this insult, of course, I will heal. So when the body heals, the valvulitis will also heal. But unfortunately, the valvulitis heals with scarring. Just to give you an example, we know that mitral valve is a bicuspid valve, right? It has two leaflets. This is one leaflet, this is another leaflet, and the point at which these two leaflets approximate each other, this is what we call as commissure. This is called as commissure. So when inflammation happened, these leaflets were swollen, and when they heal with scarring, and that scarring results in commissural adhesions. The commissures get attached to each other a little bit. So next time when the valve is opening, this opening may be reduced. Now it cannot open completely like before. It can only open in this region. This was story of one attack of rheumatic fever. Next time if I get one more group A beta hemolytic streptococcal infection, again the same process gets triggered. Again valvulitis happens. Again I can have MR, but this time little more scar. When I heal, again little more scar. So eventually when I keep accumulating scars, my mitral opening becomes extremely narrowed down, right? Now this opening is too small for the flow of blood from left atrium to left ventricle. At that point of time, I will start calling it as mitral stenosis. So when this happens, I will call it as RHD. So what is RHD? RHD is an outcome of repeated attacks of rheumatic fever. So why we give penicillin prophylaxis? The penicillin prophylaxis is given because we have to prevent this group A beta hemolytic streptococcal infection. Otherwise, every time infection happens, little bit of extra scar tissue appears on the valve. So if I prevent this, I can prevent the progression towards the mitral stenosis or RHD, right? So if the patient had a past episode of rheumatic fever, he is at risk. His immune system is always trigger ready. Every time, next time the beta hemolytic streptococci come, the immune system is triggered, some damage to valve. So multiple episodes, more damage to valve, right? If I've started antibiotics in the early course of the illness, like after the very first episode of rheumatic fever, and if I maintain the penicillin prophylaxis as per the guidelines, unlikely that he will progress to rheumatic heart disease. But if I'm starting penicillin prophylaxis quite late in the course of illness, already he has gone through tens of episodes of rheumatic fever, then he might have already got the valves which are reasonably damaged. I can only prevent further progression of the valve damage, but I cannot reverse this damage. So he might be already a case of RHD by the time I'm starting the penicillin prophylaxis. Okay. So the progression is preventable, but the damage is not reversible. Okay. I hope that is clear. Okay. Sutapa Samantha, let me see. I missed it. I get. Sutapa, you had mentioned that cachexia is not present in this case. So yeah, of course, I was only talking about the differential diagnosis at the level of complaints. Right. So when we take more detailed history, the weight loss, the unintentional weight loss may favor the TB or cancer as a diagnosis. If there is no weight loss, the TB or cancer become relatively less likely, right? Absence of one feature or presence of one feature never completely rules out a disease, right? Just because someone is not losing weight doesn't mean that he is not a case of TB or is not a case of lung cancer. But if he is losing, the situation becomes likely that it is a TB or lung cancer. We should always keep in mind. Okay, so with this we will sign off today. So in the next class, we'll start discussing the general physical examination. We will concentrate on the 6 basic parameters, that is pallor, icterus, clubbing, cyanosis. Many times when you present case, this is where examiners tend to fail you because you don't know the basics of examining for the pallor, basics of examining for the cyanosis or clubbing. So we'll go it in a methodical way. So I'll sign off today. The notes will be available on the Telegram channel from where you can download. Okay. Thank you all guys for connecting. See you soon.